My hope is that by the end of the hour, you'll be able to differentiate between secondary traumatic stress, compassion fatigue, and vicarious trauma, as well as moral injury and burnout. So you have a sense of some of the potential predictors and indicators of the different conditions, and that you'll recognize the effects that these conditions can have on us as providers, the clients we serve, and the organizations that employ us. So a little bit about me. My current role is as of Executive Director at Ham Memorial Psychiatric Clinic. We're an integrated mental health clinic in St. Paul that's been around since 1954 with psychiatry, psychotherapy. We have psychologists and social workers and nurses, and we really want to provide wraparound care in a community mental health setting where we offer a sliding fee and a variety of different services. Prior to HAM, I've only been here for about a year. I've been in trauma exclusive environments. So I kind of grew up as a therapist in programs at Domestic Abuse Project and started as a clinician working with child witnesses to domestic violence, and then with men who use abusive behavior, and kind of moved up in programs there and moved up into administrative roles. I then went to Corner House, which is an interagency child abuse evaluation center, and oversaw our case management advocacy and built a psychotherapy program there. And then I came here to HAM, and kind of woven through that, I've worked with a lot of immigrant and refugee populations. So I was at Center for Victims of Torture for a while, and then at Lutheran Social Services in the Refugee Resettlement Department doing trauma therapy. And the reason I come to this topic the way that I do is I hit the skids pretty hard, pretty early on in my career, and realized that I needed to have a good understanding of these different concepts so that I would be able to do something about it and stay doing the work. In addition to my role at HAM, I teach at the University of Minnesota the trauma class and methods classes, how to do therapy, and then do some training and consultation on the side through a PLC, mostly helping trauma organized systems kind of stabilize, and then helping organizations create wellness and sustainability plans based on some of the things that we're going to talk about today. So yeah, so my hope is that by the end of our time together, you'll really have a sense of how to view this. The framework has really shifted from a self-care framework to a work sustainability framework, and to view things in the context of them being an occupational hazard rather than an individual provider weakness. That it really is about the ways in which we're exposed, and the research fully backs that up, and that we, individual factors don't do much, including self-care, in terms of mitigation of the effects. So we're going to go through definitions, we're going to talk about some risk factors, and then we're going to talk a little bit about the signs and symptoms. So to start with definitions, you don't suffer from traumatic stress, which is an umbrella term for these different frameworks, if you're indifferent. Our treatment technology in the social services is empathy, but we know helps is relationship. There's a ton of research about that. And what we know is that having empathy for someone who is suffering is part of what helps people heal, bearing witness to that suffering. And so, but you don't experience these things if you are indifferent to clients' experiences of suffering, which most people don't get in the field to be that way. So it's important that we understand these different terms correctly. The research on this is still relatively new. The research around secondary traumatic stress began in the late 1990s. So we have just about 20 years of research, but it is extremely compelling. And if there's a lot of overlap in using terms, but I feel strongly that when we have great clarity, then we can properly identify what's going on and then use a strategy that is actually going to be effective for what the identified problem is. And as I said, we really need to shift organizations from seeing this as an individual problem, and even subtle messages from orgs where you say you're feeling affected and the response is, what are you doing to care for yourself? Implies that if we're not taking enough jogs on the weekend, that we're not doing what we need to prevent these work-related stress conditions. And the reality is that that isn't the case, that this is really about how much exposure we have to client suffering. So just to start with the first part of the PTSD definition from the DSM-5, which is the Manual for Mental Health Disorders. It's published every 20-ish years. The APA, American Psychiatric Association, for those of you that are familiar, tends to move really slow. And so these changes, the fact that they made such significant changes in 2013 for this iteration of the DSM is really speaks to how profound the research is. So this is the inclusion criteria for what's considered to be a big T trauma. So big T trauma is something that causes our physiological system to go online and respond neurobiologically and physiologically to threat. So the person was exposed to death, threatened death, actually threatened serious injury, or actual or threatened sexual violence as follows, either direct exposure or witnessing in person. Now, this part of the definition has been relatively the same since the late 1970s. And what's really profound is the addition of these two other inclusion criteria. So the first addition is indirectly, by learning that a close relative or close friend was exposed to trauma. If the event involved actual or threatened death, it must have been violent or accidental. So this was based off of research that was done looking at friends and family members, particularly those that lived with someone who had a primary trauma exposure. And what they found was that the symptoms of secondary exposure alone were often nearly as high or as high as the person that had the primary exposure to the trauma. Working at Corner House, I saw this all the time, working with children and adolescents who had experienced sexual assault. Their parents were often, very often, exhibiting symptoms of PTSD at the same rates as their child, despite not having a direct exposure. The next piece here is for most social service providers. This is repeated or extreme indirect exposure to the aversive details of events, usually in the course of professional duties. For example, first responders collecting body parts or professionals repeatedly exposed to the details of child abuse. Doesn't include indirect non-professional exposure like TV, media, movies, and pictures. So this is really specifically focused on professional exposure to trauma, and that there are a lot of different ways that we get that exposure in our day-to-day work, but now it's included. So if you meet the other criteria of PTSD, you can be included based on secondary exposure at work alone. So I'm going to go through some of the different concepts now. The first is burnout. Burnout is a syndrome of exhaustion, depersonalization, and reduced personal accomplishment. So the core of burnout really is about exhaustion, physical, emotional, mental. Burnout does not require that we have any particular exposure or exposure that's specific to client stories of trauma. So this is really about doing people work. And it can be equally applied to maybe an MFIP worker that isn't hearing stories, sometimes they still do, but that isn't necessarily hearing stories, and, a trauma therapist all across the spectrum. The core to this one is this over-involvement with clients and overwork. And the research on burnout is, this is the highest risk of the different conditions that we're going to talk about. And the core of it is that there's a real risk related to exploitation of clients. The question isn't if there'll be a boundary violation. The research shows the question is when a boundary violation will occur. And so we need to take a more intentional approach around managing burnout. Burnout is really primarily associated with workload. So this is employment in organizations that are typified by high demand and low personal reward, which is most of the social services. And low personal reward is defined in this specifically by, going home into your personal life with significant financial reward or political reward. So the idea is that you either come home with a really big paycheck and a lot of sociopolitical power. And if that's not the case, based off of the position that you have, then likely it would account for this. And then client caseload is characterized by chronicity and complexity. So you have the same kinds of clients coming in with the same kinds of problems, and sometimes the exact same people are coming in again and again, and sometimes it's really hard to help them move through whatever the problems that they're bringing to services are. And this is also, most of the social services. So the major interventions overall for burnout management are workload interventions. This is about the physical space that we work. It's about having control over our, who we're seeing, when we're seeing them. It's about having diversity in our workload, or specifically in our caseload, and then also in our workload. So you're not seeing the exact same type of client over and over again, and you have other responsibilities that you can pivot to if you're feeling overwhelmed by the work supervision or administrative responsibilities, sitting on a committee, things like that. Those are meant to be the most helpful for burnout. The second construct is vicarious trauma. Vicarious trauma, the core of vicarious trauma is a breakdown in belief system. So this is a transformation in our schema and beliefs as a result of feeling empathically connected to client stories of trauma. This can result in significant disruption in our meaning, connection, identity, worldview, and affect tolerance, along with some other things. I had a mentor who used to talk about this as this kind of falling of the veils, that you would get into the work and you saw the world one way, and then typically more slowly over time, you start to see the world in a really different way, because you start to see people's acts of goodness and their acts of harm more acutely and more pervasively. And so vicarious trauma is just a shift in the way that we think about and understand the world. In terms of vicarious trauma, management strategies are most primarily related to meaning making and a connection to something bigger. This can be whatever your reasons are for engaging in the work, but being able to stay connected to that. So that might be some sort of structured religion or philosophical beliefs. It could be a sense of meaning making in nature, connection to others, but that meaning making and in the more acute moments where this is present, a real emphasis on tangible acts of care. And we'll talk about that a little bit more, but rather than working on emotion processing through it, typically what's most helpful are the same types of things that we do in society when somebody experiences a death or a loss, that we do a lot of really concrete, tangible things for that person, typically. So vicarious trauma, a good example of this is I had a supervisee when I was at Corner House who talked about she had regularly gone with her niece and nephew to the playground, and she did that about every other week. She would take them on the weekend to the playground, and she said that she started to notice at the beginning, she would kind of get in there and run around on the equipment with them and play and be playful and disinhibited. And that over time, she started to notice that she moved from being as playful with them to sitting more on the bench and watching her niece and nephew play, watching other families, and that she would notice her thoughts really shifted from, rather than previously kind of delighting and watching these families have these moments together, starting to wonder, I wonder if you assault your children, I wonder if you assault your children, I wonder if you assault your children. Started to see the whole world based off of whether children could or couldn't be safe. And that's a very good example of vicarious trauma. Yeah, so that's that construct. The third construct is secondary traumatic stress. Secondary traumatic stress is a little bit more straightforward. It's simply symptoms of PTSD in the worker. So it's the same kinds of things that you see in post-traumatic stress disorder represented in the worker themselves. And it can happen really abruptly, really acutely, or it can be kind of a slow accumulation. People's symptoms of secondary traumatic stress tend to kind of wax and wane with time, depending on caseload and exposure. So very similar symptoms to PTSD. Intrusion and avoidance of trauma reminders. This can be sitting at dinner with friends and family and wanting to be able to be present in the conversation with them, but you keep thinking about a client situation or a client that you're worried about or something that happened to them. And then you try and push it out of your mind because you want to be able to be present with your family. That would be intrusion and avoidance. Heightened arousal. Often this is related to sleep. So it can be the hypervigilance of being really attentive to safety in your environment and other people's affect, but it can also, and being jumpy, but it can also be having a hard time with sleep. Sleep is dealing with insomnia or dealing with sleep issues like restless sleep. Exhaustion, fatigue, emotional strain, feeling like it's too hard to connect with someone empathically. Feeling just unable, competence can feel really undermined by some of these symptoms. So feeling unable to really help people the way that one would want to help them. And it can lead to a PTSD diagnosis. And the difference between secondary traumatic stress and PTSD kind of fully really is about threshold. So you can have some symptoms of secondary traumatic stress, but if you meet the threshold for a full PTSD diagnosis, which also includes impairment in functioning, then you would have that. There's been lots going on lately around talking around moral injury and its application to social services and the hospital system. Moral injury is perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations. So this is, any one of these four things. Engaging in an act that you wouldn't typically want to engage in if you were trying to create the best care you could for someone. Not being able to prevent something harmful or hurtful happening to someone. Bearing witness to, and often this can be, watching someone else in your, like that supervises you do something that you would otherwise not do because it goes against your moral beliefs, or learning about something that does that. And we feel powerless to address the situation, and potentially betrayed from the authority structure itself, or authority figures or peers. And that event, what happened, is really discrepant with our fundamental beliefs about how the world should work and how people should be treated in the world. And so this is more like there's an active transgression that needs to happen, but I would say it's also kind of a pervasive transgression. So with vicarious trauma, there is a requirement that you are exposed to client stories of suffering. With moral injury, you don't have to be. They're kind of in the same realm, but moral injury can be working in a resource-scarce, overburdened system that requires too much of people. It can be being in a mental health environment where you're seeing way more clients than you really should be to provide adequate care, or a place where revenue is driving most of the decisions about people's care. Those kinds of things can result in moral injury. I would say also systemic oppression results in moral injury. It can also result in vicarious trauma because it's a traumatizing act. But some of these big systemic things, in addition to what happens in the specific systems that we're working in. And it results in this dissonance and inner conflict. With the moral injury, protective factors are often holding a belief in a world that is ultimately just, forgiving supports and self-esteem in the research are really helpful. Meaning making is a big part of moral injury, the same way that it is part of vicarious trauma. It's really helpful for that. And self-forgiveness. So this is in your slides. We're not going to go through the whole thing, but it just kind of breaks down if you're trying to kind of understand the differences between these. Burnout and moral injury don't require trauma exposure. Secondary traumatic stress and vicarious trauma do. The core feature of each of them, the primary cause. So burnout is about caseload. Moral injury is an act that transgresses our moral beliefs. Secondary traumatic stress is exposure to suffering with a special focus on kind of the imagery or the visceral aspects of what that other person's trauma was. So giving details about, what the room looked like, or what the trauma smelled like, that sort of thing. And then vicarious trauma is just general exposure to suffering. That same mentor that I had that was, she was a little on the dramatic side, and she would say, vicarious trauma is being engulfed in anguish, sinking in despair. But it really, this kind of alienation from others is more core to that. And then the primary interventions, if you're going to prioritize one thing. So for secondary traumatic stress, the primary intervention is really doing things that one would typically do for a PTSD diagnosis. That could include going to therapy, but there are many, many different cultural supports that help to treat PTSD symptoms. It doesn't have to happen in a psychotherapy environment. But despite all of this, we do the work for a reason, and that is compassion satisfaction. So we often are motivated by something, some sense of compassion, something that we get from these relationships where we're helping others, something that sustains and nourishes and motivates us. And I think one really important thing when we're thinking about our own work sustainability is thinking about what this is for you. it is really different for everyone. I know for me, I've realized over time and doing a lot of work with complex trauma survivors who change moves really often at a much slower pace with, how important it has been for me to be able to notice small changes. And that's what really sustains me. It's being able to notice a child that I'm seeing in play therapy, they hide behind their parent's leg and don't want to come in and are trying to avoid coming to sessions because the content is hard with the processing. And then they start to come in and bolt ahead of their parent and run up the stairs to my office before they ever, before they would never have done that. So just noticing that, or noticing the client that comes in with, many layers of clothing and 2 sweatshirts and a jacket and all their hoods are up, and they like take down the first hood or make eye contact for the first time. I've had to learn that noticing those things really helps to nourish me when often change feels like it's happening really slowly. And change being even building a relationship is happening more slowly than with another client that doesn't have the same kinds of trauma. Another term that's often used is compassion fatigue. Compassion fatigue was a term that was created by Figley to be more quote unquote user friendly. It's meant to be an umbrella term for secondary traumatic stress and vicarious trauma. I have mixed feelings about the word, but it's meant to kind of encapsulate those in a way that's easier to understand. The research on compassion satisfaction and compassion fatigue is that we can feel both at the same time, but at some point we experience so much fatigue that we can't actually access the compassion. All right. I'm just going to share 2 quick studies. There's so much research on this, but this is one of the earlier, more seminal studies that was done on secondary traumatic stress. It was with 282 randomly selected licensed social workers in Georgia. And what it found was that 70% of those in direct practice were exposed to STS through their work with traumatized populations, so a high percentage. And independent of any other traumas a social worker directly experienced, so kind of controlling for personal experiences of trauma. They found the rate of full-blown PTSD in social workers due to indirect exposure alone was twice that of the general population. And this is only looking at prior week. So only looking at symptoms for the prior week. So if you think about that over the course of a year with symptoms kind of waxing and waning, it's a large percentage of our service population. This is the other study. I like this study a lot because it breaks it down into kind of the layers of symptoms. This is a sample of 256 LICSWs. It was a mailed survey with a pretty good response rate. 41.7% had mild to high STS, and 35.7% met criteria for PTSD, 86 more than 1 in 3. And every study now that comes out looking at emergency room nurses, looking at social workers, looking at law enforcement, the average number for of the sample that meets full-blown criteria for PTSD is hovering between 30 and 40%. And so just think about that. This is again prior week reporting, that 1 in 3 of our colleagues or we are experiencing full-blown post-traumatic stress disorder due to indirect exposure alone. They thought that peer support might be enough of a buffer for this, so they found 88% reported that they get along with peers and 74% reported good or very close emotional connectedness. So ultimately, it wasn't that individuals that had higher rates of symptoms had less support. They had a lot of support. They felt very supported, but 57% reported wanting more structured time, more time that's structured in the workplace. So we're going to jump in now and talk through some of the potential risks. So these are just kind of things to think about that might increase the severity of symptoms related to any of these different constructs. So the first is our personality and coping style. There's a good amount of research on this one. If we have a tendency to avoid our own pain or other people's pain and we take it in and kind of shut it down and not process it, processing it is really important. And you can do that in a variety of ways. It can be in supervision, it can be with a colleague, it can be verbally, it can be written, it can be through time for self-reflection, but we need to make sure that we're actually processing it. That is a really important mitigator for experiences of secondary traumatic stress and vicarious trauma in particular. So we need to get better. Social workers need to get better at asking for support, trying to understand ourselves, and really trying to actively problem solve. This is one study that looked at this, 160 social workers in public agencies, and it found that coping strategies on either end of the spectrum, either emotion-focused strategies, where people are kind of dysregulated and really focused on how they're feeling emotionally, on the other end, avoidance strategies, people are saying they're fine, they're fine, they're fine. Both, when tested, have much higher levels of secondary traumatic stress. Having our own personal history of trauma, there's a good amount of research on individuals in the helping professions that are quote unquote wounded healers. And most of the research shows that average percentage is 60 to 80% of the social service population, you know, at least, has their own personal history of trauma. And so, so this is just a fact of it. And when we think about the average childhood experiences studies, this makes perfect sense. But it does mean that we're more susceptible to a higher level of symptoms. Working with more traumatized clients, and this is all about exposure. More exposure, higher symptoms. What they found was that dispositional optimism, mastery, and weekly supervision were associated with lower secondary traumatic stress. So dispositional optimism is really kind of hopefulness, hoping for the best, trying to take a positive outlook. Mastery is feeling a sense of ability to control one's life and environment, rather than feeling like the world keeps happening to them. And they only looked at weekly supervision in this study. In other studies, they've looked at supervision and have found that it isn't, supervision is very important, but it isn't about the frequency, it's about the quality. So it isn't about quantity, it's about quality. So even if the supervision is happening not weekly, if it's quality supervision where the person feels like they can fully show up in the space, that is a major buffer for experiences of secondary traumatic stress, partially because it provides us a holding environment to process our experiences of exposure. You know, as I said, our own personal histories, who we are, affects us in terms of how we experience these different constructs. So it can help or hinder us in our work with clients. This isn't to say only experiences of trauma. We need to know ourselves and know ourselves well and kind of be able to scaffold ourselves or brace ourselves if there's something that we know is more vulnerable for us, because we can't always predict which clients are going to share something that's harder for us versus the ones that won't. But knowing our strength, knowing our vulnerability, those things are really useful. And I would say this is even just generally knowing where your sweet spot is in terms of the clients that you're working with. So doing DV work for a long time and working with lots of clients that had difficulty with anger, I'm really comfortable working with angry clients. I could work with many angry clients in one day. They can be very angry at me, and I can stay really regulated through that. I have supervisees who working with angry clients completely dysregulates them and they can't get kind of back on track the rest of the day. For me, I really struggle with working with very lethargic, depressed clients. I feel like I have a harder time kind of connecting and getting us moving. And so for me, I am not my best therapist on my third client that is really severely depressed. And so I know this, and I don't schedule 3 severely depressed clients in a row. But I have lots of colleagues that's their jam and that's what they do really well. And so they can certainly do that. So it's just kind of, as we grow as professionals, learning this and then doing what we can with it, scheduling our week, advocating for ourselves based off of what our strengths and areas for growth are. Our current life circumstances, so stressors like home, family relationships, one would hope that you have all sorts of things happening in your life outside of work, but these things can also be stressful. And we, I think, often want to believe that we can put a hard line between work and home, and that work doesn't affect our home life or our home life doesn't affect work. And the reality is we have a finite amount of emotional reserve. And if we're really depleted from home, of course, it's going to affect how much emotional reserve we have at work, and that's okay. And the amount of emotional reserve that we have depleted at work is going to affect how we show up at home. And so all of these things are going to also affect how much we're able to tolerate in terms of client and how saturated we feel in terms of client narrative. Our social supports. It is really important to have people in your life who understand your work and it is really important to have people in your life that don't. I have a little brother, his name is Freddie, and Freddie is a computer programmer, and he doesn't know anything about the social services, and it is glorious. I get to, when we get to go out to eat or go do something together, I just get to be my personal self, the sister part of me, the family member. I don't have to hold my professional identity in that space. And that's really lovely. But I also need the people in my life, other people that do this work, that I can go to dinner with and I can say I had a bad day. And they like know in their bones what it means to have a bad day. They can feel that. I don't have to say anything else. So I encourage you to think about that. I also encourage you to think about who in your life, you know, one of the things that happens a lot is that people that are in helping roles, whether it's predating them getting into a formal helping role, or just generally they tend to have a number of relationships that aren't reciprocal in their lives, or they tend to give more than they receive. And so I encourage you to think about your relationships, think about who is in your life, whether those relationships are reciprocal, whether you're getting your needs met too, and then figure out what your needs are and identify barriers to having those needs met. Social isolation, this is actually the only thing I learned in grad school, was that social isolation is highly correlated with higher risk for traumatic stress. So before I took my first internship and as I was working my first job, I was really, really intent on not feeling secondary trauma. I thought I could control it. And so I tried really hard not to socially isolate. So I was really intentional about trying to make sure I was spending time with friends and family and, you know, out. And I super overscheduled myself in order to try and manage this. And about 6 months in, I remember talking to my clinical supervisor and being like, I'm feeling really affected, but I'm doing what I was told to do, which is not socially isolate. And he looked at me and he said, Angie, you're an introvert. It was the worst possible strategy for me to try and do that. So thinking about this, but also knowing that balance is really important. Spiritual resources. So this is really especially related to vicarious trauma and moral injury, but maintaining a sense of connection to a source of hope, meaning, and purpose. I had a colleague and former supervisor who would talk about she did a ton of trauma work for a very long time, and she would talk about how her meaning making system was what she called the garden patch philosophy. The garden patch philosophy for life. She was a gardener, and gardening was a really important part of her life. And she would say that her, you know, philosophical or religious belief system really was developed through gardening. That in gardening, she would see the cycle of life and she would realize how little power she had over things ultimately. She would talk about, you know, you can plant the flowers, you can take care of them, you can make sure that everything has the right amount of nourishment and sunlight and water, and ultimately you can't control whether a bunny comes and eats the flowers. And so it kind of was a constant reminder to her of what she does and doesn't have control over, and that nourishing something doesn't necessarily mean that she can control outcome. And then our work style, we need to be able to work appropriately, manage appropriate boundaries at work, and have really reasonable expectations for what we're able to do in the work. Other risks to the situation are role, work setting, and exposure based off of exposure alone, working more directly with more people in need and hearing more distressing stories or seeing more distressing scenes and events. If you're getting primary exposure as well in your job, which is many social service positions. A sense of responsibility without having the resources that we need to help as many people as we would like to help do their job well, or do our job well, excuse me. And working long engagements or moving from one difficult assignment to the next without time for rest or processing in between. I joke that I need stare at the wall time, which is really just time to decompress and reorient. And in a mental health clinic, often you're back to back with meetings and appointments, and you know, when we're seeing clients for a 53-minute hour, it doesn't leave enough time to kind of integrate how much content can happen in the hour you have before and kind of prepare for the next one. So this is a big challenge. Agencies that work as top-down hierarchies with little opportunity for those at all levels of the organization to communicate their needs, and for leadership to be communicating openly and transparently why decisions are being made on all levels of the organization, is a major risk factor. The research on this shows that people don't actually need to have what they want to be the outcome as the outcome, that people need to know that regardless of the role they occupy in the organization, kind of the corner of the organization that they're viewing things from, that they're valued, and people believe, and it's true, that each individual has a unique perspective on the problem, and they can generally trust, people can generally trust people in leadership roles, if they believe they've been heard, to adequately synthesize all of that information and then make a decision that's in the, a missional decision for the organization. But people need to feel like their perspective is genuinely heard because they have data that someone else in the organization wouldn't have. Agencies need to recognize how demanding the work is and create organizational cultures intentionally that are supportive and provide adequate time off and not overwork staff chronically. Another risk factor is the situation. We work with populations that have a variety of responses to their experiences of trauma. In my work with refugees and asylees, one thing that was really interesting was that many of my clients had incredibly resilient ways of managing their experiences of trauma. My clients would often bring in prayer and poetry, music, food, community, time, all sorts of different ways of connecting and moving through that experience. Often many healthy coping skills. And my work at Tap and Corner House, places where the trauma was often much more chronic and interpersonal, typically in family of origin. My clients had a very different range of responses, often co-occurring disorders, using chemicals to manage the painful effects of the trauma they've had. They've experienced difficulty with connection and trust and building relationship, shutting down and not engaging, or becoming more easily dysregulated and angry. And because of mirror neurons, we mirror what our clients are experiencing neurobiologically. And so we end up taking on these responses, and that can be us individually, but also can be the systems that we work in, can replicate the trauma that clients are bringing in. And then our cultural context. We have many layers of cultural oppression related to trauma survivors. Society has typically pretty negative attitudes about individuals that experience trauma and those involved. We do a lot of victim blaming, denying, minimizing the effects of trauma on individuals, and a lot of looking away as a society. And then the society's attitudes about different groups within society. So thinking about your client base, are your clients being devalued or oppressed as a result of racism, sexism, homophobia, transphobia, classism, xenophobia, etc. So all those layers are added on. And the layers related to attitudes about helping professionals in general. So I often ask when I'm doing this training in person, what are things that people say or don't say to you when you tell them what you do for your role? And it gives us a lot of clues about how people see and experience helping professionals. And then additionally, culturally, your own style of expressing distress and extending and receiving assistance. So thinking about your own, middle childhood, 5 to 10 years of age or so, how were you taught to express distress? How are you taught to identify your emotions, express your emotions? What emotions were you allowed to express and weren't? How are you taught to ask for help? All the messages that we get about those different things. I typically share that I have a German-Swedish ancestry, and my grandmother was a very stoic Swedish woman. And she died a couple of years ago at the age of 99 and a half. But at 99 and a half, I had not seen her, and I mean really genuinely, a single time in my entire life express an emotion. She would chuckle a little bit occasionally, but mostly she wouldn't show experiences of joy or sadness or anger or anything else. And it was really culturally based. For her, it was an act of love and care that she didn't do that. She really deeply believed that expressing those things, including positive emotions, puts your emotions on somebody else and makes someone else responsible for them. And so she was taught and did, and my dad did the same sort of thing. He was a much more sensitive person, but still more stoic. And so I grew up not really getting a lot of direction about emotions. I remember getting to grad school and seeing a feeling chart and being like, whoa, there's so many different feelings I'm going to have to learn how to articulate. And so thinking about this for yourself, about how you move through the world when you're feeling upset or affected in one way or another. The culture of the work, think about your professional culture, your training is it medicine, social work, psychology, criminal justice, nursing. What are the messages you got there? Our professions are typically characterized by things like self-neglect, toughing it out, taking risks, denying our own needs. And I see this come up most often with people when it comes to their schedule. So when I work with staff, often they'll try and protect their lunch hour, or they'll try and make sure that they get out a few days a week by 4 or 5 p.m. And, one client really needs that slot, and then suddenly another client needs another slot in the evening, and now they're working 3 nights a week when they only need to be working 1 night a week. And so really putting our needs before other people's needs to happen for us to sustain in the work at times. So the last piece is talking about some of the consequences, signs, and symptoms. This is a quote I like a lot from Perlman and Sakvatine, which is, the defense is employed to protect oneself from the knowledge of people's capacity for cruelty have their own costs. So we do a lot in order to not have to be attentive to how hard it is to watch other people hurt one another. Some of the concrete signs and symptoms are changes in our worldview or frame of reference. This can be changes in spirituality, beliefs, meaning, purpose, causality, connection, hope, faith. We can question our prior beliefs. One of the more common things that happens with trauma survivors is a period of existential questioning. Am I good? Am I loved? Why did this happen? Is the world good? Is the world safe? Does God love me? Those kinds of questions, and often that similar questions come up for providers. And it can result in this really deep sense of loss and purposelessness, hopelessness. And at times it can move us into being much more cynical or just feeling a really profound sorrow. And so these changes in our spirituality are really important, and we need to do what we can to provide a foundation and scaffold that and continue to reconnect to our purpose and meaning. This can be making sure that you have quotes up in your office or poems or things that kind of reconnect you to why you did the work, pictures of things that reconnect you to why you're in the work. But we need these reminders connecting our day-to-day with our larger purpose. So this one says, my question is, are we making an impact? Changes in identity. So the ways that we think about and practice our different identities. One of the more common things that happens is that as people feel more and more alienated from their personal self, they practice their personal roles less frequently, and they lean more and more into their professional role. This has happened most often in early career professionals, but it can happen across the professional lifespan. And it's because we start to feel really disconnected and uncomfortable with the versions of ourselves that we are in other places, as we try and navigate the version of ourselves as a helping professional. And then changes in our beliefs related to major psychological needs. So when they do research on vicarious trauma, the scale that they use looks at these 5 constructs. They look at safety, control, trust, esteem, and intimacy. And they look at each of these in a self and other dimension. So self-safety, do I believe I can keep myself safe? Other safety, do I believe other people can be safe? People I love. What is my need for control? Do I believe I have control over my thoughts, feelings, and emotions? Do I believe other people have control over their thoughts, feelings, and emotions? Do I trust myself? Do I trust others? Do I feel good about who I am? Do I believe other people are good? Can I be vulnerable and authentic with myself is the intimacy? And can I do that with others? So our worldview can shift, and we can just start to really feel like we're highly vulnerable to harm. And the people that we care about are highly vulnerable to harm. And I'm aware that how I'm talking about this right now in the midst of everything that we're going through as a society. But this is that, but it's, I think that can catalyze worse symptoms. But this is really about, is the world safe when you see so many people experience such harm? So this can be really concrete things. One of the things that I have noticed I do is really, I had done work in domestic violence. I knew that children could get hurt. We moved to corner house, but sitting, you know, across parent after parent after parent, where the parent is telling me, I vetted this person, I knew this person, I trusted them, I checked in with myself to make sure I trusted them, and I can't believe they sexually assaulted my kid. After you sit across from enough parents that say that, it's really hard to believe that you have some different capacity to assess people's safety. And so I have a hard time ever imagining sending my kids on a sleepover, even though I know that that's not a real logical belief, that lots of people go on sleepovers and it's perfectly safe. But after sitting across from hundreds of people with that beliefs or with that experience, it can change the way that you orient to things like that. And these things affect our loved ones. We can be disconnected. We can have more conflict in our relationships. We can generally withdraw, kind of go inside. Increased dependencies are really common. Addictions, nicotine, alcohol, food, sex, shopping, internet, etc. Finding ways to disconnect or numb. And I think in this, one of the things to know is any increase in secondary traumatic stress over the previous 12 months is highly correlated with increase in substance use, even if it's just going from 1 drink a week to 2 drinks a week. And we can have the silencing response where we feel like we're really unable to pay attention to other people's distressing stories, especially in our personal life, because we feel overwhelmed by them and they're kind of incomprehensible. And we can minimize the pain of others. We can say that isn't really a problem. Other people are experiencing real problems. Trauma is a real problem. This isn't a real problem. This one says, listen, pal, they're all emergencies. Effects on our loved ones, our symptoms affect them. We can become overprotective. We can have a hard time sleeping and that disrupt their sleep. We can be less interested in sex. It's important to discuss these things with your people, not just speculate. Because of this overwhelming sense of grief, it can mean that we have a hard time connecting in ways that we used to connect, and sharing with them how you're experiencing your symptoms and asking for what you need. These things can affect our work. We can make decisions without really reflecting, mistakes that cost time or money. We can take on too much and not fulfill commitments, take unplanned time off. Often that happens because we end up experiencing real somatic symptoms because we suppress so much of the effects of this on our emotions. And we can infect others with our own cynicism, depression, lack of motivation. We also make more mistakes. We have more clinical errors, the more vulnerability we experience. So we might have more therapeutic impasses, or we don't complete treatment. We think people aren't motivated. We diagnose them with something that they don't have. We become more frustrated when they're not complying with our idealized response to services. And it can really undermine our own sense of our competence and skill. A particular risk with this is sometimes we might become too intrusive, just like in trauma, asking for specific details of the client's abuse, or pushing them to confront a perpetrator or leave someone that's hurting them before they're ready. Or we can become really avoidant and not want to talk with them about their trauma. We can rescue instead of support, so jump in and do on behalf of the client, see them as more fragile or more vulnerable than they are. And there can be a role reversal where clients are protecting us from their distress or impairment, not telling us about the things that they would otherwise tell us because they can sense that we're not well. And this creates an unethical bind because it's exploitative of the client. The relationship should be that you're providing care for them rather than them to you. And we can engage in behaviors that are negative with our clients and in the workplace. Be unresponsive to clients' needs. This is a common one. We make promises to clients, I'll get you that resource or I'll follow up with this. And then we have a hard time actually doing that. Some concrete signs: you may find yourself reluctant to check messages or return calls. You might have an unseemly delight to cancel appointments. You might come to agree with a client who's complaining about their own sense of frustration or pessimism. You may begin to doubt that what you're doing is effective and have a hard time getting your day started. And we may have really unreasonable expectations of ourselves in the work. We think we should be able to work well with everyone, even when that's not the case. That we need to be the perfect model for health and mental health. We should be on call all the time, put our clients' needs before our own. Feel personally responsible for client choices that are ultimately theirs. And feel like we should have more control in our clients' lives and thus feel really responsible. This says we just haven't been flapping them hard We can become really obsessed about one client and withdraw from work with other clients. Wish a case would terminate, really change our work habits. Maybe we're typically really good at getting paperwork done and now we're really struggling. And I'll have staff that'll say, I just have my blinders on, I'm gonna come in and do my job and, you know, not engage anything. And that says a lot about how overwhelmed and overstimulated someone is, if they wanna just come in and disengage in every other way possible. So it says, no Thursdays out. How about never is never good for you. So just to end with some basic considerations, organizations need to make sure that staff have adequate time off, sufficient orientation. Orientation should be both to the structure of the job, getting your keys, knowing how to get onto email and internet, things like that. But it also needs to be training into content, training on trauma, training on secondary trauma, and the ways that the organization thinks about and engages in the work. Maybe concrete plans for staff safety. This includes active shooter training now, security training, and briefing on protocols. Good access to medical and mental health support services. EAPs are wonderful. Support for families around things like childcare and separation. People really need to know that their personal lives are valued by the organization they're working in. There should be real encouragement of genuine connection at work to increase morale, genuine affection between people. Working in teams is a huge buffer for this because it's a good avenue to connect with others, but also celebrating life events and other things, having outings together. And genuinely providing a voice in decision-making from all staff in the organization and clear communication from the leadership through the entire agency about what is changing, why, how, and in a timely way. And then helping build more diversity and job enrichment in the work and encouraging people to genuinely take breaks to kind of reset. As managers need to understand the psychological and spiritual impact of humanitarian work. We need to understand how these cumulative exposures affect staff, and we need to check in, not just expect people to check in with us, but we need to check in with them and talk about how they're coping, and just assume that at times they're going to be feeling these things and support them in getting the help they need. We want to set an example by how we care for ourselves, from modeling, working sustainably and reasonably, openly valuing things outside of work, taking our PTO, acknowledging that this is hard and work-life balance is not a destination, it's a journey. And then when things are especially pressured, that we look for ways to help staff keep our challenges in perspective, that remind people that we're all in this to forward a mission of the organization, and that this organization's mission fits into a larger movement, a movement for parity for mental health, or a movement to end domestic violence, that we're all part of something bigger. And we need to remind people that the organization values people as people, the organization's most important resource, and not just for the work they can do. And helping people work sustainably or plan for breaks if work sustainability can't be done in the immediacy. And then we need to really stay positive and acknowledge effort and results whenever possible. And when people are giving feedback about their job and the organization, that needs to be heard and valued. So the kind of final thing I just want to share is about this model for self-care that I really like. So self-care, organizational interventions are going to be the most effective for managing secondary traumatic stress, vicarious trauma, but we also have a responsibility to do some things to take care of ourselves. This is called the REP model. So there's 3 parts: relax, escape, and play. Relax is quiet time with our thoughts. So this is being with your thoughts, meditating, breathing, stretching exercises. Escape is getting as far away from your thoughts as possible. So not trying to not process things. This is books, movies, video games. And then play is doing something active with our body. So playing with kids, exercise, art activities, all of these things, create things that bring out creativity and joy. And then that's just the very last thing, which is remembering that our society has this narrative about happiness and joy, that it's this place, this destination that you get to and then you just feel it for months at an end. And the reality is that joy is an emotion like every other emotion. It comes and goes throughout moments in a day, not these long expanses of time. And that humor is one way to experience joy. There's a quote I love that's laughter is the closest distance between 2 people. And then also sensory experiences. So from a mindfulness-based perspective, we can carve out 20 to 30 seconds at work, even if it's not 20, 30 minutes, to enjoy the first bite of our lunch when we're eating our lunch really fast in front of our email, or to notice the way that the sun is kind of dancing on our bedspread when we wake up in the morning, or if you're going to wash your hands, that you're getting the temperature just right and you're enjoying that sensation rather than feeling like it's just another thing to push through. So that's what I got.
Great. Well, thanks very much, Angela. Really appreciate your presentation today. I'm not practicing anymore other than a little bit for Walk-In Counseling Center as a volunteer. But I certainly saw myself in many of those examples that you brought up along the way, because I did a lot of trauma work. And the other thing is, I hope that one thing you learned in graduate school was from me in one of my classes.
Probably it was. Yeah.
So we have one question, maybe another, but from someone, from a Sarah, who says, can you provide an example of moral injury? Would this be like an ethical violation in one of the situations you described? For example, very high caseload of mental health clients working a resource scarce area.
Yeah, I mean, I think that it can be, so there's a, what I would encourage you to do is that there's a gentleman that goes by the name of Dr. Z. He does this YouTube channel. He's a doctor, and he talks about moral injury. So if you Google YouTube Dr. Z moral injury, it'll show a video that talks a lot about what this feels like in systems. He's talking from a medical framework, but it's the system itself and its acts within the system, like not being able to do a phone call with the client and get paid for it because they're too ill, but they still need some connection and support. And then maybe being discouraged for doing that. I mean, that kind of thing would be a simple example.
Okay, I think that's it. So again, thanks so much, Angela. Really appreciate it. And for everybody else who's still on, that email will be coming with the post-test link, as well as the PowerPoint PDF of Angela's presentation attached. So that's it. See you in a month, next second Friday. And there are descriptions of the next 2 webinars now on our website, which you can register for. So signing off. So long.
All right, sounds good. Thanks.
Bye, Angela.